Hello, this is Wiesje van der Flier from Alzheimer's Center Amsterdam, and I'm really happy to talk to you today about developments in diagnostic tests and how they help to identify and quantify risk of brain disease. And the context of this talk really is the shift in the diagnostic paradigm of Alzheimer's disease, or AD, that we see the past years. And originally, Alzheimer's disease dementia was defined as a syndrome characterized by memory loss and impairment in activities of daily living. We now see a shift to a biologically defined construct. So Alzheimer's disease is defined by the presence of amyloid and tau and/or neurodegeneration, and this can now be identified using biomarkers in living individuals. And this means we can identify and also quantify brain disease. This also implies that we can identify Alzheimer's disease before the stage of dementia, even before symptoms occur. And that implies that before, when we talked about Alzheimer's disease, this was a diagnosis. Now it becomes more a prognosis, because when you know you have Alzheimer's disease, the real question is, will I develop dementia, and when? So what does this information imply for personal lives of patients when they know they're amyloid and or tau positive? And should you even share this information about amyloid positivity or tau positivity in individuals who are not yet demented? Well, to address these questions, we conducted a number of studies. And we started by asking patients and caregivers, and we conducted focus groups with patients and caregivers looking back on the diagnostic process. And they said they actually would have wanted more information about their test results. And particularly, they valued information on the likely impact of these test results on their personal lives. So this was looking back on what happened. And then we did a prospective study where we actually listened in to patient-doctor conversations before and after diagnosis. And what we found is that although most doctors frequently discuss in rather 2 out of 3 conversations the information on specific tests they were going to use, we also saw that the doctor did not really invite additional questions or ask whether a patient actually understood what had been said. We also found that the decision whether or not to embark on specific diagnostic tests, such as MRI or PET or lumbar puncture, was really led by the doctor. And the patient and caregiver only rarely initiated questions, only in 2% of the conversations. And this was rather in contrast to the survey data, because right after the conversations, we conducted a survey with the patients and caregivers, and actually 1 out of 4 of them expressed a need for more information. But what was the information that they would have wanted to have? To address this topic, we conducted the Delphi study. And in this Delphi study, we asked 3 groups of participants, 1 group of patients, 1 group of caregivers, and 1 group of professionals, which informational topics they would find most important to discuss in the doctor-patient encounter before and after diagnostic testing. And based on literature, expert opinion, current guidelines, we identified 44 topics, which we offered to all panels in 3 rounds, online rounds, where patients, caregivers, and professionals could indicate whether they found a topic very important or not so important to discuss. And we defined consensus if more than 75% in each of the 3 groups indicated a topic as extremely important. And in doing so, we found a topic list of 17 items where all 3 groups agreed that these were extremely important topics to discuss before and or after diagnostic testing. And these 17 items could be grouped into 4 categories. There were items on diagnostic testing. What would be a goal to perform a diagnostic test? What would be a reason why a test cannot be done? What would be the possible outcomes? And if a test had been performed, such as neuropsychology or an MRI, then of course the test results should be shared. There were also more general topics on diagnosis related to diagnosis, such as the certainty that a certain result will actually explain the complaints, or the consequences of a certain diagnosis, or the prognosis of the complaints. And finally, there were also topics concerning very practical implications, such as what's the next step in my diagnostic process, or when is my next appointment, but also questions about the driving license. In addition to these 17 items where all three groups consented that they were extremely important, there were also 8 items where 1 or 2 groups thought this was extremely important, but the third group did not agree. And here are 2 examples of these topics. One is difference between Alzheimer's disease and dementia, and the other is a risk estimation for developing dementia. And what you see is that for both these topics, patients and caregivers consider these extremely important, while the professionals found this less important to discuss. And what would be the reasons for that? Well, arguments in favor of discussing the difference between Alzheimer's disease and dementia would be increasing knowledge and reducing stigma. Would also be that different causes of your complaints imply a different prognosis. So this is relevant to know for your future, to prepare for your future. And arguments against discussing such a topic would be the overload in information and the fact that it's really rather difficult to understand. And quite similar arguments were provided for the risk estimation for developing dementia. People would prefer to have this risk estimation because it would allow to recognize the symptoms sooner and understand better what would be the cause of the changed behavior. It could also help to prepare for a possible future. And the arguments against sharing the risk estimation for developing dementia would be to cause the anxiety to cause unnecessary fear or anxiety. And again, it would be difficult to understand and explain. So this topic list can help actually prepare patients and caregivers for their visit to a memory clinic and become more empowered. It also provides professionals insight into what patients value. And what we see here is that the topic of risk estimation is clearly valued very highly by patients, but it's really not that easy. And that's why also the arguments against discussing this topic are so prominent amongst the professionals. So here we looked in a group of cognitively normal individuals who presented at a memory clinic with complaints. So they were worried about their memory, but they were thoroughly investigated for their cognition and for the presence of disease at Alzheimer's Center Amsterdam, and they were deemed cognitively normal. So no disease at the moment. And then in this group of cognitively normal individuals, we applied the ATN model. And this is really the model that describes Alzheimer's disease as a biological construct based on the A for amyloid, the T for tau, and the N for neurodegeneration, the 3 aspects of Alzheimer's disease pathology. And there were almost 700 participants, on average 60 years old, roughly half of them female, and they performed quite well on their cognitive test. And you see there the biomarkers we used to define A, PET, or CSF with the lumbar puncture, the T, CSF p-tau, and we used medial temporal lobe atrophy for the N. And then based on these 3 biomarkers that were all abnormal or normal, we could categorize each of the participants in 8 categories. And you see them depicted in the pie graph. And you see in green that the majority of these individuals had all 3 biomarkers normal, as would be expected, because these were cognitively normal elderly. Stage 2 Alzheimer's disease, this means no cognitive problems, but Alzheimer, amyloid, and tau are both positive, was present in roughly 9%, these red, 2 red pie pieces in the pie. So that's a minority, but it does exist, Alzheimer's disease in people who are actually cognitively normal. So what is the clinical relevance of this finding? So here you see a graph of what happened over time. On the x-axis, you see time over 5 years. Here you see at the bottom, everybody was cognitively normal. And every time the line goes down, somebody developed dementia. So over on average 3 years, a small minority of 22 individuals developed dementia. And what we see is that those in stage 2 Alzheimer's disease, but also those with the T and the N abnormal, so with more biomarkers affected, were more likely to develop dementia. It's also relevant to know that even after 5 years, more than half of the individuals who were positive for the biomarkers did not yet develop dementia. So what we see that on a group levels, the biomarkers are indeed informative predictors of progression to dementia. But we also need to be cautious here. But on a cognitively normal population, prognosis on a group level, like we see here in a research setting, cannot be directly translated to the individual level because we don't know what will happen to a specific individual. So you should be cautious when you interpret these data on an individual level. This individual level is more within reach for the group of patients with mild cognitive impairment. So these are patients who experience memory problems, but they do not yet have dementia. And when we follow a group of patients with MCI, over a period of 3 years, on average, 50% of them, half of them would develop dementia. So they're clearly closer to the dementia stage. And what we see from research is that we have more data sets, more cohorts with both biomarker data and long follow-up available. And we use these data, these biomarker data, to provide probabilities of dementia at 1 and 3 and 5 years follow-up on an individual level. And we showed that this was actually feasible and robust across cohorts. And again, we use this ATN model, so the 3 biomarkers for Alzheimer's disease pathology. And here we'll see there is a statistical measure which shows that the model is rather good. It's not perfect, but it's rather good. And this shows that for MCI patients, a prognosis on an individual level of dementia based on biomarker data is within reach. And this is shown also in this very colorful isograph, where you see that the tau measure on the x-axis and the A-beta measure on the y-axis and the atrophy, so that's the MRI measure in the 3 panels, can be combined to actually come with individualized predictions. And of course, this graph is really nice, but it's rather difficult to implement in daily practice. And this is why we also developed an app, an e-tool, which we call the ADAPT, to support communication on diagnosis. The ADAPT is currently a prototype, so it's only a research tool. And actually the risk calculator is available for professionals only, so it's behind the login. In this same tool, you can also find the topic list, and this is accessible to the general public. But what you see here is that we have in the ADAPT both the risk calculator, where you can very easily fill in the biomarker data of a given individual with MCI, and then the risks come out of it. And there's also, as you see on the right panel, a communication sheet which supports the professional to explain what the biomarker results mean for the personal life of this individual patient. And with that, we come to the conclusions of this talk. And what I've tried to tell you is that we can actually diagnose Alzheimer's disease before the stage of dementia. But this novel knowledge comes with novel challenges. Is it ethical to tell these results? Is it ethical not to tell these results? What we see in any way is that patients and individuals want more information than we currently provide them with. And so we should do better at informing patients of what has been found and what this means for them. And I also think that at the basis of deciding whether or not to embark on diagnostic testing and which diagnostic tests to perform, the patient and the caregiver need to be involved in this decision. So this is what we call shared decision making. And it also requires quite some communication skills, not only on the side of the professional, but also on the side of the patient and the partner, that may become more empowered to actually raise their voice. Among the big advances in research in the field of Alzheimer's disease is that we do now have these diagnostic tests to identify brain disease and quantify risk. So biomarkers based on MRI, the PET scan, and in blood and CSF are really available and can identify Alzheimer's pathology in the brain in living individuals. We see that with these biomarkers, individualized risk profiling is actually within reach for individuals with mild cognitive impairment. For individuals who are cognitively normal, I would be rather reluctant because the models are not that good yet, that I would say that it's really feasible to give a concrete risk estimation in individuals. So in a general, be cautious because risk communication can never be better than the models it's based on, and the models are never perfect. So this is actually the disclaimer. And back to this conference where we are, Think Brain Health. And I think that, and that's really the bottom line of today, is when you know whether your brain is at risk, you can then actually act to preserve your brain health by either enrolling in a trial, by making plans for the future, by adapting your lifestyle, and thereby helping keep your brain healthy. And with that, I would like to end, but not before sharing with you the entire group at Alzheimer's Center Amsterdam, and particularly Agneta, Ingrid, and Leonie, whose research I've shared with you today. Thank you.